Hello and welcome to today's webinar, Tailoring Medicaid Physical Behavioral Health Integration in Washington State, Lessons for States, made possible with support from the California Healthcare Foundation. Before we get started, I'd like to go over a few logistics. To eliminate background noise, phone lines are being muted during today's event. There will be a moderated question and answer session following today's presentations. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on chcs.org. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I will now turn the webinar over to Logan Kelly, Senior Program Officer at the Center for Healthcare Strategies.
Great, thank you so much, and welcome everybody to today's webinar. I'd like to again thank the California Healthcare Foundation for generously supporting today's webinar. And today we're excited to explore how Washington State moved towards greater physical behavioral health integration. And we'll really focus in on how this state's approach was tailored to the strengths of its different regions, as well as lessons for other states and stakeholders that are interested in advancing integration. On our agenda, we'll first hear welcome remarks and a brief introduction about the national landscape for integration. And then we'll hear from a state leader in Washington's integrated managed care program, who will describe the state's approach and some of the initial outcomes that have been observed. And next we'll hear from two leaders at the regional level on how each of their respective regions transitioned to integrated care in a way that leverage their regional strengths and capacities, and they'll highlight lessons from those initiatives. And then finally, our presenters will all answer questions submitted by all of you during the webinar. So please submit questions anytime by clicking on the Q&A icon at the bottom of your screen. Next slide. As you'll see here, we have an excellent lineup of speakers today, and I'll fully introduce each one before their respective presentations. Next slide. And then I'll just briefly provide some information about the Center for Healthcare Strategies. CHCS is a nonprofit policy center dedicated to supporting innovations in care delivery and improving the health of low-income Americans. So we work closely with states, health plans, providers, community-based organizations, and other stakeholders towards these goals. And one of our three areas of focus that you'll see on the screen is integrating services for people with complex needs, such as those with behavioral health conditions. Next slide. And next, I would like to invite Catherine Tier, Associate Director for High Value Care at the California Healthcare Foundation, to share some welcome remarks.
Thank you, Logan. On behalf of the California Healthcare Foundation, I'm happy to welcome so many of you to the webinar. The California Healthcare Foundation is a nonprofit, independent philanthropy dedicated to advancing meaningful, measurable improvements in the way the healthcare delivery system provides care to the people of California, particularly those with low incomes and those whose needs are not well served by the status quo. We're especially focused on strengthening Medi-Cal, California's Medicaid program, the cornerstone of California's safety net. At the Foundation, we believe that integrated care that incorporates physical health, behavioral health, and social needs leads to better outcomes, and we know that consumers prefer it. So the Foundation is interested in models that integrate care both at the clinical delivery system level and at the administrative and financial level, and we support work in those areas. Along with our partners, we recognize that California's siloed systems need to communicate and work together in new ways, and if we didn't know it before, the last 6 months have really made it clear. We also know that California is not so special in this regard and that many other states face the same challenges, and we're committed to learning from other states' experiences. So that's the background for today's webinar, which we think has important lessons for California, but for other state Medicaid programs as well. I want to thank the Center for Healthcare Strategies, which organized this presentation, and particularly want to thank our colleagues from the state of Washington, who are generously sharing their time and expertise with us today. Thanks too to all of you for joining the webinar today, and I'll now hand back off to Logan. Thank you.
Great, thank you so much, Catherine. Next slide. To share some additional background for today's webinar, we really wanted to underscore that many states are pursuing greater integration of physical health, mental health, and substance use disorder care with the goal of improving care for individuals with behavioral health conditions. And as I'm sure many on the webinar today are familiar with, we know that those with behavioral health conditions have more chronic conditions and worse health and social outcomes. And this group has higher costs as well. In Medicaid, spending for enrollees with a behavioral health diagnosis is 4 times higher than for those without. Much of this excess spending is actually due to increased physical health spending. And as well, many individuals with co-occurring conditions experience fragmented care across their physical and behavioral health needs. And there's an increasing body of evidence that clinical integration of physical and behavioral health services can improve health outcomes and quality of life. Next slide. And since integrated care can take place at different levels, as Catherine mentioned in her remarks, below we wanted to provide some working definitions on what these terms mean. As a way to support individuals experiencing integrated care, a number of states have moved towards financial integration, which is integration of the purchasing and management of physical and behavioral health services, often through integrated managed care organizations. Additionally, there are many initiatives to improve the clinical integration of physical health, mental health, and substance use disorder services at the point of service delivery, so individuals experience integrated care. And clinical integration is often described as a continuum, which is illustrated at the bottom of this slide. Next slide. And among states with Medicaid managed care, there's been a trend in recent years towards including behavioral health in their health plan contracts. In 2019, 31 states had an integrated benefit for at least part of their Medicaid enrollees. And on this map, the states in blue have integrated financing for physical and behavioral health in their managed care organizations, and the states in green carve out the behavioral health benefit to either behavioral health managed care plans or to fee-for-service. And the states with yellow diagonal lines, which I'm hoping show up on your screen, have additional integrated plans that are specifically designed for individuals with serious behavioral health conditions. And while it may look like just a small number of categories that show up on this map, every state is different, and every state's approach needs to build on state-specific strengths and needs. And so today on this webinar, we'll hear from a state that has looked to advance more integrated and coordinated care within a fully integrated managed care system, but with insights and lessons that can be broadly relevant across other models and environments. Next slide. So to speak to that state example, next I would like to introduce Teresa Claycamp, Integrated Managed Care Program Manager at the Washington State Healthcare Authority, who will describe Washington State's journey to integration and some of the early outcomes observed to date. Welcome, Teresa.
Thank you, Logan. I appreciate that. Good morning. Thank you for the opportunity to speak with you today regarding Washington's journey towards integration. My name is Teresa Claycamp. My background really briefly is I'm a licensed mental health counselor who worked at the behavioral health community level for a better part of a decade. And I joined the state in 2016, right as we began our integration process. So that's my background, is more of a provider perspective and a provider background. Next slide, please. So today, I'm going to just talk really briefly about the goals and design of our integrated managed care program. I'm going to talk briefly about the role of our managed care organizations, as well as the role of our behavioral health administrative service organizations. And I will talk about the implementation of integration since 2015 and some of the details with that, and then touch upon some initial outcomes that we have seen with integration. Next slide. So our journey began in 2014. There was a legislation that was passed that essentially changed how Washington State purchased mental health and substance use disorder services in Medicaid. It directed the state to fully integrate the financing and delivery of physical health, mental health, and substance use disorder services in the Medicaid program by 2020. It allowed for an interim step where we developed and stood up behavioral health organizations that integrated mental health and substance use disorder treatment as an interim step to integration, and with a full implementation by 2020 that would add physical health. I would just like to note that this legislation did allow for a phased approach to integration over a 4-year time span. We have 10 regions in Washington State, and each region had choice on what timing they would like to implement integration. So some regions chose to be early adopters of integration, some chose to be mid adopters, and some chose to be what we call on-time adoption. I really think that this phased approach was a good way to approach this. This is a huge system change, and I think to do it all at once would have been not a good idea. So I think allowing each region choice as to when they would implement was very helpful. We also worked with our largest region, which is King County, to allow them to have a slightly different structure to their integration. And Isabel Jones will be speaking about that later on today. So in summary, you'll notice that we did allow for some flexibility, some regional nuance to the approach to integration so that this could be done over a 4-year period. Next slide. So why integrate? So Washington State historically had what I call a trifurcated system. We were very fragmented. We essentially had 3 separate systems, each administered and managed by different state and agencies and entities. So we had a mental health system that was our regional support network, service networks for mental health. We had a separate SUD system that was county administered for substance use disorder treatment. And then we had a physical health system under the healthcare authority with our managed care organizations. And so this was quite fragmented. So the idea of moving towards an integrated system was to first and foremost create a one-payer system that was one payer that was accountable for keeping for basically whole person care. And so you can see on the right-hand side of the slide, some benefits of integration. It's a journey, it's a process. Just because we implemented the financial integration of the system and the administrative part of the system, there's still a lot of work that needs to be done on the clinical side. Next slide. So this is just a snapshot of what implementation looked like over time, over the 4-year period. The regions are color coordinated, and you can see that each region implemented at a kind of a different time. We had an early adopter, and then we had a handful of mid adopters, and then we had what we call our on-time adopters. So it definitely was a phased-in approach to the integration process. Next slide. This is just a snapshot of the managed care organizations per region. You'll notice that the larger regions have 5 managed care organizations in the region because the population supports it. And some of our smaller regions only have 3. We require a minimum of 3 managed care organizations in those regions because we want individuals to have choice. And so this is just a current snapshot of what the managed care organizations look like per region. And because of COVID and our increase in Medicaid numbers that we're seeing since COVID, we are actually adding some managed care organizations in 2021 to some of these regions because of the increase in need. Next slide. So the managed care organizations, in a nutshell, many things remained the same as we integrated. So the managed care organizations are still responsible for all state plan services. And they also cover crisis services for their enrollees. And the way that they do that is they subcontract with the regional behavioral health administrative service organization. So they still cover the crisis services with that through that subcontracting arrangement. And they're also responsible for the inpatient stays, both voluntary and involuntary, for their Medicaid enrollees. We do also provide state funds to our managed care organizations to cover things that that are medically necessary but not covered by Medicaid. So things like room and board or rehabilitation case management to individuals that are in jails or hospitals, things like that, personal care, stuff like that. So there is a portion of funds that we provide through, it's called a wraparound contract to our managed care organizations for those items. Next slide. And Joe Valentine will do a really great job talking more about the role of the Behavioral Health Administrative Service Organization. But in a nutshell, each region has an administrative service organization that is responsible for the non-Medicaid services. So crisis services for sure, behavioral health services for low-income non-Medicaid individuals, and they also receive any federal block grant dollars for mental health and SUD services. It is interesting to note that, again, just kind of building in that flexibility with how we implemented, we allowed each region the right of first refusal. So what that means is each behavioral health organization in each region had the right to either become the ASO for that region or decline. And so you'll notice that in our state, a lot of the former behavioral health organizations transitioned to becoming the ASO for the region. And I think that worked really well. There's a lot of continuity with that. Those BHOs know the regions and really have a lot of knowledge. So that, I think that worked really well, allowing for that regional voice and regional presence. There were 3 regions in our state that decided not to become the ASO, and we did procure that to a private entity, essentially. Next slide. This is just a snapshot of our contracting structure. So you'll see that the Healthcare Authority contracts obviously with the MCOs, as well as that ASO. So the red box in the center, the red dotted line, is the ASO for each region. And so the MCOs contract with the ASO subcontract for those crisis services that I was talking about. So that's just a quick snapshot of what the contracting arrangements look like. Next slide. So successful transition. We tried really hard to implement solid, proactive, and reactive measures, essentially, in implementing each region. And like I said, it was a phased approach. So we had a group of regions that implemented earlier. We really learned lessons with that and then tried to apply that to the later regions that adopted later. So first and foremost, we had targeted readiness processes. So what did that look like? Very proactive measures where we did provider readiness symposiums, so that we did a lot of training, obviously partnering with our managed care organizations. We did monthly readiness meetings to try to make sure that everybody was prepared for the go live, is what we would call it. We facilitated knowledge transfer meetings between our former behavioral health organizations and the MCOs and the BH-ASOs to make sure that there was knowledge being shared and learned from each region. We also did a lot of readiness reviews and technical assistance monitoring with our managed care organizations and our ASOs in each region to make sure that they were ready to implement. The other thing I would stress in this readiness process is to have providers test their claims processing procedures. So make sure that they're working with each MCO and ASO to make sure that the claims are flowing, and we really recommended people do that early, months before go live, to make sure that claims were flowing, because that was an area that was a challenge. As far as additional monitoring measures, we did basically, as we implemented each region, we did what we call rapid response calls. So what that was is basically pulling together our MCOs and our provider community and our ASO for each region, and we would jump on the phone for 30 minutes, 3 times a week, to just make sure, is everything going okay? What's not? What's working well? What's not? and to try to problem solve and troubleshoot early on in those first couple months to make sure things were going smoothly. So we did that in every region. The other thing we did was our early warning system process, where we had set metrics we looked at, things like number of crisis calls, whether claims were going through, whether claims were being rejected or denied, number of ITA investigations. So we looked at early warning system metrics each month in a webinar format with the MCOs and with our providers to say, what does this data say? Are things going okay? What does, do we need to make some adjustments? So we definitely did that. The other thing I would stress is with the implemented regions, we did ongoing provider learning forums. And I think those regions that had those provider forums really benefited from that format. So that's another recommendation. And then next slide, I will conclude with just some early outcomes from the early adopter regions. So we partner with our research and data analysis division for data analysis. And they have been looking at about 30+ measures since the inception of integration. And those measures often go ahead and they leverage HEDIS measures or our state-developed HEDIS measures. And they look at things like access to care, coordination, and also the social determinants of health. And we have been looking at those measures since implementation. And the way that we do that is we look at the region's data compared to the rest of the state, how the rest of the state is doing. And then we looked at that integrated region to see how they're doing. So this is an early snapshot of our first region that adopted integration, which was Southwest. And we did see some pretty favorable results early on, and you can see that on your screen. Things around substance use disorder penetration rates, mental health penetration rates, follow-up after ED visits, and then also the percent employed. So again, getting at some of those social determinants of health. We did see a couple of indicators that weren't favorable. Those were around comprehensive diabetes care. So hemoglobin A1C testing did not show favorable. And then we did see ED utilization wasn't favorable. So, we did look at a couple different areas. So that's just an early snapshot of our first region. And then on the next slide is our second region, which was North Central. Now, North Central is a very small region. It's the smallest region in our state and has the smallest number of Medicaid enrollees. And also, what's unique with North Central is that their utilization's always been utilization data's always been fairly low, and in fact was pretty low going into integration. So we did see some favorable, but not as well as the Southwest region. And so, 4 measures showed statistically significant relative improvement, mental health penetration, follow-up after emergency visits, and percent arrested. That was one that they were pretty excited about. And then again, there were many measures that showed no difference when compared to the rest of the state. And then we did have 3 that declined. So compared to the rest of the state. So that's just an early view of some of the outcomes. We're now in a position working with our research data analysis partner to start to look at the 2019 data. And we'll be looking at that as well. We're a little bit behind because of COVID, but I look forward to looking at 2019 data because that would include all of the regions that were mid-adopters of integration. And so we will be looking at those outcomes. I want to thank you for your time, and I will go ahead and pass it back to Logan. Thank you.
Great, thank you so much, Teresa. And I am just now sharing in the chat box a link to a case study that has more information on Washington State's transition to fully integrated managed care. And so we've received a number of great questions so far. And if you're interested in learning more, we'd recommend checking out that case study. And next we would, we'll hear from two leaders in two different regions of the state that have implemented fully integrated managed care. And really explore how their regions have approached this transition. And so first we'll hear from Joe Valentine, Executive Director of the North Sound Behavioral Health Administrative Services Organization. Welcome, Joe.
Hello, thank you. I appreciate the opportunity to be part of a discussion of sharing ideas with other states. I think that's really helpful. This is a very complex task. It's one we need to do, and I think the more we can learn from each other, the better. A word about myself and a word about the North Sound region. I have been in public social services management for over 40 years. For the last 8 years, I was a director of North Sound Behavioral Health in all of its different iterations. Prior to that, for 7 years, I was a director of the Contra Costa County Employment and Human Services Department in California. So I am familiar with kind of the contrast between California, more of a county-centric approach, to Washington, where more of the services are state-centric. And it's interesting to compare and contrast some of the advantages and disadvantages of each approach. So if we go to the next slide, a word about the North Sound region, which I've circled on the map here. It is the second most populous region in terms of population, about 1.2 million people, and over 290,000 Medicaid enrollees. It's also a geographically diverse and challenging region, spanning urban, rural, suburban, and very isolated areas such as the San Juan Islands that you can only reach by boat or plane. So it presents some unique challenges as a region. If you go to the next slide, a word about our history. So in the late 80s, early 90s, the counties kind of petitioned the state to turn responsibility for community mental health services over to the counties as an effort to focus on keeping people out of the hospital. The North Sound counties have a history of pretty passionate involvement in mental health and behavioral health. And so in 1991, the 5 North Sound counties created a regional support network, which became the Public Mental Health Authority. In 2006, the state transitioned paying for mental health to a managed care approach. So the entities received a per member per month payment for mental health services. In 2014, the legislature then integrated substance use treatment into that managed care structure, which enabled the state to better access Medicaid funding for substance use services. So we transitioned the regional support network into a behavioral health organization in 2016 and took on the responsibility to operationalize that integration. And then as Teresa shared, in 2019, we then transitioned to become a behavioral health administrative service organization. Again, the counties in our region who historically have been very involved in oversight of behavioral health wanted to maintain that role in the system. So if you go to the next slide. So briefly, with integrated managed care, the Medicaid responsibility was integrated in the Apple Health contracts. Non-Medicaid services were contracted with the behavioral health administrative service organizations. In most areas, these were the same entities as the behavioral health organizations. And just to note that the board of directors for our entity has always been elected officials from the 5 counties. And so they continue to exercise oversight of the behavioral health administrative service organization. So next slide. So what are we responsible for? Teresa briefly touched on this. A core responsibility is crisis services, which includes a 24/7 crisis hotline. It includes mobile crisis outreach teams, and it includes involuntary commitment services. But in addition to that, the ASOs receive state funding to provide services to other uninsured, low-income, non-Medicaid persons. A footnote on integration, which has integrated care for Medicaid enrollees, but kind of revealed a gap in services for that next tier of persons who are not eligible for Medicaid, but who have inadequate or no insurance coverage. And that includes persons who are dual eligible Medicare and Medicaid. So in order to address that gap in the system, the state provided state general fund dollars to the ASOs. We also receive federal block grant funds, both mental health and substance use. We are responsible for discharge of non-Medicaid persons from state psychiatric hospitals. We continue to be responsible for community planning, and I'm going to put an asterisk on that responsibility and talk about the significance of that in a little bit here. And also we are responsible for a behavioral health advisory board, which includes at least 51% of persons with lived experience. If you want to go to the next slide. So in planning for implementation, one of the challenges that we faced is by going from one entity responsible for the behavioral health system to 6 different entities, which is the 5 managed care organizations and the ASO. We had to recreate a structure for planning and coordination. And the interlocal leadership structure, which Teresa mentioned, let me say a word about that structure, because that's a key structure. It was based on a model developed in King County, and eventually the structure was actually put into legislation, and it allows for the 5 managed care organizations for our 5 counties, for ourselves as the ASO, and Native American tribes, which we have 8 of in our region, and behavioral health providers to formally work through a structure to plan and coordinate implementation of behavioral health on an ongoing basis. So basically trying to recreate the structure that was in place with a single entity. Underneath that, we have an operating committee, which is the managed care organizations and our organization, focusing specifically on trying to coordinate between the crisis services system and integrated managed care treatment system. And that's been a major focus for all of us, is to identify persons who are frequent utilizers of crisis services, trying to figure out how to leverage the strengths of the integrated managed care model to provide better services to those folks. As Teresa mentioned, we had to spend a lot of time training providers and training ourselves on the integrated managed care model. And that included knowledge transfer webinars. We also in our region have a strong history of coordinating with the tribes, who also themselves are providers. And we meet regularly with our crisis services leadership. So if you want to go to the next slide. So some of the challenges that we encountered right off the top of the bat was the providers, the behavioral health agencies, really did not have adequate electronic health record systems to do business with the managed care organizations. One of the things that we did is that we were able to use some money made available to the state through a waiver process to provide funding to the behavioral health agencies. We provided over $6 million to behavioral health agencies to upgrade their electronic health record systems. And even that was barely enough. Teresa mentioned the early warning system. In the early months of implementation in our region, providers were experiencing a certain percentage of their claims being rejected or denied. And for behavioral health agencies who kind of operate on a slim margin to start with, that was having some real problems with their cash flow situation. It was just a different way of doing business. And in our region, because all 5 managed care organizations were serving our region, that meant those agencies had to have separate contracts with each managed care organization who might have slightly different billing and reporting requirements. So that was a major hurdle to deal with right off the bat. Related to that is that at least initially, the managed care organizations were relying primarily on a fee-for-service reimbursement system. And for some services that we traditionally funded capacity rather than fee-for-service, for example, crisis facilities, detox facilities, residential treatment facilities, who they had to keep all of their beds open at all times. A fee-for-service approach created some real funding challenges for them. Another challenge is that by splitting Medicaid off into separate organizations and leaving the state general fund dollars with the ASO, we kind of had a balkanization of funding, which is in a sense having separate funding streams rather than under the BH-ASO, we were able to kind of braid some of that funding together. I think another issue is that the goal of the model is integrated care, but I think the challenge is, at least at the outset, there was little pre-existing on-site integration of physical and behavioral health, with the exception of maybe a few behavioral health agencies. So really, in terms of clinical integration, which is the bigger challenge now, really kind of starting from scratch. And finally, the approach for integrated managed care, using managed care organizations who create purchasing networks versus a community system of care under the other system, kind of highlighted the tension between a state approach and a community-driven approach. And again, we were able to use planning structures to bridge some of that tension. So if you want to go to the next slide. However, the state's model has created a lot of opportunities that did not exist before prior to integrated managed care. Clearly, one of them is supporting improved access to physical health care. And that was accomplished in part by care coordination for high-risk persons. So the managed care organizations were able to assign care coordinators to folks to help them access physical health care that they may previously had challenges in accessing. So I think that's a huge opportunity. Another benefit created through this model is that the managed care organizations had the flexibility and resources to provide other kinds of supports to their members. And that included cell phones for folks to contact their healthcare providers, food vouchers. This was especially helpful during COVID, where some of the managed care organizations literally were providing food and housing vouchers to their members. So that was a huge support. They also were able to pivot during COVID to provide more flexible funding support for the behavioral health agencies. I mentioned the challenges that the fee-for-service approach had out of the starting gate, but as the behavioral health agencies began to experience even more serious cash flow problems, the managed care organizations were able to pivot and started providing some creative ways of funding to stabilize their funding, either through some type of advance payment or capacity payment. So the flexibility that managed care organizations had actually turned out to be really helpful during COVID. I think another opportunity is that the managed care organizations have to comply with national standards for quality of care, the NCQA standards. That was kind of foreign to our behavioral health agencies. And I think by providing those standards and training those standards, I think it's helped begin to raise the overall quality of care for behavioral health. And then finally, I think the model has moved us farther along the path that you saw on an earlier slide towards physical and behavioral healthcare integration. I think the financial integration has occurred, and I think the next task really is the clinical integration. So if you want to go to the next slide. So some of the lessons learned is don't underestimate the level of technical and financial assistance needed for behavioral health organizations to operate under this model. It was just too foreign for them. And the challenges of dealing with electronic health record vendors was quite challenging. They often didn't have the sophistication to select a vendor that would really meet their needs, or they would select products that had little or no flexibility for them. So this was a huge issue. And the vendors themselves, we discovered, really weren't ready yet to take on this kind of heavy lift of moving this many organizations into a new platform. So that was a huge issue. I think a second lesson learned is to hold harmless the negative financial impacts. So again, right out of the starting gate, by flipping the switch to pure fee for service, agencies immediately started to experience cash flow problems, partly because they didn't have the sophistication in their systems to get their claims through. And I think discovered over time that you really kind of have to keep them stabilized while you move them towards this other structure. A third lesson learned is that fee for service does not work for all behavioral health programs. You have to match the funding mechanism to the needs of the program. So some programs, such as crisis facilities or treatment facilities or crisis services, they need to keep a structure in place at all times. And if they're subject to the up and down of services to 5 different managed care organizations, it's really hard to keep viable. And then a lesson learned is that you really need to create strong and locally responsive planning and coordination structures. I think at the beginning, the counties are very nervous about the managed care organizations because they knew that they're, some of them were national, some were statewide, and the counties felt they would no longer have any influence or impact on behavioral health, even though they often saw the impacts in jails, in public safety systems. So I think creating that structure to keep that in place, it's really important. And then another one is you have to pay special attention to integrating care for persons with severe behavioral health disorders. It is one thing to integrate services in a primary care clinic for most folks, but folks with severe behavioral health disorders often report that they don't go into the primary care clinic because they just don't feel welcome there, or staff don't understand their issues. So I think integration for this population requires some additional thought and attention. And then if you want to go to the next slide. So another lesson learned is you have to create new data exchange strategies that follow the person as they move between the payers. So one of the challenges that we had is now health information was segregated actually into 6 different silos. And so for the mobile crisis outreach teams, when they get dispatched, they may not have access to information, treatment information about that person. And so they're kind of going out blind. And so we're trying to look at new platforms that all managed care organizations and we can share a common platform so that everybody can coordinate care to that individual. But that's, it's a challenge. So it's something to pay attention to. And finally, to make the model work, you have to invest more in capacity building for physical and behavioral health care. And in our region, we had a significant shortage of treatment and crisis beds given our population. And that isn't something by itself that the integrated managed care model would address. It really requires investment strategies. And so parallel to the model is you have to look at the investments that are needed in creating those new facilities, and there's new programs. And if you really want clinical integration to occur at the primary clinic level, the behavioral health clinic level, that also is going to require some additional investments and assistance. So those are my remarks. And again, thank you for the opportunity to share these thoughts.
Excellent. Thank you so much, Joe. And as a reminder, we've received a lot of great questions so far. If you have a question that you'd like to ask to our presenters today, please share that by clicking on the Q&A icon at the bottom of your screen. And next, I would like to introduce Isabel Jones, who is the Deputy Director at the Behavioral Health and Recovery Division at King County. Welcome, Isabel.
Hi, thank you so much for having me on this presentation. We can go ahead and go to the next slide. So I'm just going to start with a brief overview about King County, and then I will go into how our model is unique in King County. King County is the 14th largest county in the United States. It is home to Seattle, Washington, and it's the most populous county in the state of Washington. We have about 2.2 million people in the county and about 600,000 Medicaid enrollees. We have a large urban population here in King County, and it is the most demographically diverse county in the state, with an increasing population of foreign-born minorities, up to about 25% now, which requires more culturally appropriate services. We also have a large population of individuals experiencing behavioral health issues, as well as a large homeless population in Seattle. And then I certainly want to touch for a minute on the large local investment in the behavioral health system that we make here in King County. In King County, we have a 0.1% sales tax known as the Mental Illness and Drug Dependency Initiative. And this 0.1% sales tax brings in about $80 million per year. That is before COVID, and we are of course experiencing a shortfall right now, but typically it's about $80 million per year. And because we have such a significant amount of local funding that we invest directly into the behavioral health treatment system, this helped make our unique integrated managed care model both achievable as well as, I think, acceptable to our state partners and managed care plan partners. We are directly investing the $80 million per year primarily into the Medicaid treatment system through a variety of mechanisms that expand the Medicaid treatment system, as well as kind of support infrastructure. We also have many braided funding models that I'll talk about throughout this presentation. And then we also leverage the Medicaid treatment system and our local dollars to be able to fund behavioral health services for non-Medicaid eligible clients. So our local investment is very much intertwined with the behavioral health Medicaid treatment system, and was one of the reasons why King County wanted to pursue and was able to pursue a unique integrated managed care model. Next slide, please. So I'll just touch a little bit on our vision as we embarked on implementing integrated managed care, and it really starts with a whole person approach to care. We wanted to ensure that King County maintained a wide range of agencies and provider partners that serve all parts of our population in all geographic areas of King County. We have some areas of King County that are more remote, and we have small or niche providers that serve either geographically remote areas or specialized populations. And so it was critical from our perspective that we develop a system that would continue to support those providers and provide resources so that they would be able to stay within the network. We also wanted to maintain a strong connection to social determinant of health programs, which are largely managed at the city and county level and not at the state or Medicaid level. And this includes, for example, our Housing and Homeless Division, which is part of the same department as the Behavioral Health Division, and maintaining a strong connection both at the county level as well as the provider level to these social determinant services. We also wanted to have no wrong door to access services. This is still very much a work in progress, but our vision is that whether people come in through the behavioral health side of the continuum or physical health, they're able to get screenings and referral to the necessary services, and ultimately that we have clinical integration within our service delivery system. We also wanted to have a crisis system that adequately served our region, and because of that, we did choose, as Joe's region did, to take on the role of the Behavioral Health ASO, which maintains the contract for crisis services. And then, as I mentioned before, we wanted to ensure that we could continue braiding our local funding into the Medicaid treatment system and using local funding to meet gaps that might not otherwise be filled by other funding sources. Next slide, please. So you might be wondering, what is this unique model that King County implemented? And so I'm going to describe this starting from kind of left to right. So talking about the managed care plans and then about the provider network. So what is unique about King County is that in everywhere else in the state, the managed care plans have the contract from the state for behavioral health services, and they contract with individual providers within a region to develop a network of behavioral health providers. In King County, the managed care plans still do have the behavioral health premium. They have a contract from the state, and they are ultimately accountable to the state for behavioral health services to their members. However, all 5 of the managed care plans in King County actually chose to contract and delegate to King County the management of behavioral health services for their members. This means that King County takes on financial risk for Medicaid behavioral health services, and we have many administrative functions that are delegated to us from the plans, including contracting to the network, claims payment, care coordination, utilization management, provider relations, network management. So the health plans are really delegating management and financial risk for the behavioral health services to King County to manage on their behalf. And what is very much new about how King County now manages these services, besides being a subcontractor of the managed care plans, is King County developed a unique public-private partnership with over 40 behavioral health providers in our community who serve the Medicaid delivery system. That includes outpatient providers, specialty providers, residential providers in King County. Those 40 providers all came together into what we call the King County Integrated Care Network. And it's kind of like a association, I guess you could say, and it's very collaborative between the county and the provider network. And we have a governing structure that's up on the screen here, in which all major decisions about behavioral health services, whether that be the payment methodologies or clinical models, are discussed and analyzed and evaluated within these various committee structures, which are comprised of 50% provider network representation and 50% King County representation. So we have, for example, our performance and accountability work group, which would set standardized performance measures that can be applicable throughout the entire network. We have our clinical operations committee, which looks at clinical models and evidence-based practices and how to roll those out throughout all the providers within the network. And then ultimately, all major decisions are voted on and approved by the executive committee. So this is often has been referred to as being like an independent practice association. And I think that is a good example, although I would note that the providers do not have any shared financial responsibility amongst one another, nor do they actually take on financial risk from the managed care plans. King County holds all of that financial risk, but it is a very unique public-private partnership model. And I'll talk about the benefits, particularly to providers of this model. But really, if you think about it, the managed care plans are contracting with King County to get access to this integrated care network of 40 Medicaid service providers. Next slide, please. So I'll just talk for a minute about some of the primary benefits and impacts. Certainly for the provider perspective, the largest benefit is administrative simplification. Providers only have one payment methodology that is applicable no matter which health plan a client is with that they would serve. They only have one provider relations team. We centralize monitoring, technical assistance, training, claims payment. We centralize many different administrative functions within King County rather than a provider working with 5 different managed care organizations. In terms of clinical integration, I think there have been concerns that because behavioral health services are delegated to King County, that there are some kind of funding silos that remain, and would that impact clinical integration? And I do want to share that we have been able to achieve some of the benefits of integrated managed care from a clinical integration standpoint with this model, and primarily that's around data sharing. The managed care plans do now receive claims data on every single behavioral health service that their members receive, and they're able to use this claims data to do care coordination, do risk assessment, to determine, to really look at clients from a whole person care perspective when determining, you know, what level of care management or care coordination they might need. We have a very unique data-driven level of care stratification tool that we are now using in King County, where we can bring in behavioral health claims data, county data from the jail system and the homelessness system, as well as physical health claims information that we get through data sharing agreements with the plans and the state, so that we can actually, when we're determining level of care for a client or informing level of care, we can look at, for example, the locus assessment, but we can also look at all of this other data to understand that clients who have high social determinant of health needs or physical health needs may need additional levels of support, or providers may need additional payment to be able to support clients who are at higher risk. And again, looking at that from a whole person care perspective, not just what, you know, one specific lane. We also, for example, are going to be launching a pilot with United Healthcare soon, where we will receive daily pharmacy data feeds, and we will be able to push that out to the provider network so that providers can receive a notification when one of their clients is about to miss a refill for their psych meds, for example. And since medication has always been managed as part of the physical health benefit, that is a new and certainly a clinical integration benefit of our new model. And then lastly, one of the main benefits to our approach is that we are able to maintain our ability to grade local funds with Medicaid treatment dollars. And an example of something we're working on with this is developing a locally funded outreach and engagement incentive so that providers can do outreach and engagement to bring clients into Medicaid treatment services, but the outreach and engagement would be supported by local funding sources. Next slide. So I'm just going to touch on a couple lessons learned and challenges. So the first one is just the importance of the collaborative partnership approach that it takes to achieve something like this, both with managed care plans as well as providers. You would probably have to collaborate more than you've ever collaborated in order to implement something like this, and do a lot of listening, trust building, and compromising. I also wanted to underscore just what a significant effort it is to meet, as Joe mentioned, NCQA and MCO delegation requirements. We are essentially operating in a way almost like an Office of Insurance Commissioner licensed health plan, because we have many different NCQA requirements that we need to meet on behalf of the health plans. And for King County, we have 150 staff within our division. And as I mentioned, we have significant local resources that we're able to invest. And that does help us be able to achieve meeting these requirements. And I would also note that it would likely take over a year, if you're not already meeting NCQA standards, for example, to do the work to prepare and be ready to meet these requirements. And then just in terms of both new program startup and implementing physical health initiatives, there are several different both benefits of our model as well as challenges. One benefit I would say is that the county is very much kind of in a leadership position where we're able to drive progress and set a vision for either new programs that our community needs or new physical health integration pilots that we may want to try to work on with the providers and the health plans. And we're able to try to negotiate across the health plans and within the provider network to move some of these initiatives forward. As you can probably imagine, managed care plans are inherently competitors. And so they are not necessarily poised to organically come together and develop a joint vision to move a system forward. And so unless you have a county or the state really in a driver's seat kind of leadership role, it is challenging to bring the managed care plans to come together on new initiatives and new program startup. So that's certainly a benefit of our model. However, we still have many challenges just with negotiating amongst 5 managed care plans, working to bring them collectively together on our vision. We do still have challenges because we do still have some sort of funding silos in the sense that we only have behavioral health delegated to us. And so as we work on physical health initiatives, we have to negotiate with each plan on how that would work and how to implement. Next slide here. So I think I'm about at time here, so I'll just touch on a few things that we're working on next. One is to standardize value-based payment agreements across all of the managed care plan payers so that we can achieve incentive payments here at King County and then also provide more performance incentive payments to the network providers. We want to expand access to mild to moderate mental health services, which have always been part of the physical health benefit and have not been provided in the specialty mental health system before. This remains a challenge because, again, we're not delegated for physical health services, so we're working through all of the processes associated with that. And then certainly next for us is we want to demonstrate more relationships with primary care providers and focus much more on clinical integration at the service delivery level, particularly with primary care and behavioral health. So I think I will stop there because I know we want to have time for questions and turn it back to Logan.
Great, thank you so much, Isabel, and thank you to all of the presenters. So I'd invite all of the presenters to, you can come onto video now and we'll do our best to answer as many of these great questions as we can in the remaining 15 minutes that we have. So a few questions just touching on, I think, some details related to Washington's approach that maybe we can answer pretty quickly. One person asked, how did integration services differ for children and youth in this transition? Oh, and I apologize. Before I go ahead and start the questions, I'd also like to introduce an additional speaker who just joined us, Alice Lind, who's a clinical nurse specialist at the Washington State Healthcare Authority. We are fortunate enough to be joined by her now. So welcome, Alice. Alice, would you or would anyone else like to address that question about children and youth?
I'll just say a couple things. Joe and Isabel and Teresa might have other comments about it. In terms of the transition of the population or continuation of services, the same principles apply for adults and children in Washington State. The big difference around care for kids with serious mental illness especially is that we are under a settlement agreement which has created a very rigorous set of standards and services that are provided to children, including extensive wraparound services, and that's called the WISE program. It creates a lot of reporting requirements, but it's nothing really new to the health plans. The MCOs have been involved in monitoring WISE for some time before we did the transition. So I would say that maybe was one of the easier parts of transitioning to integration. I could just pause there, see if anybody else has any comments about that one.
Alice, this is Joe. I might mention the state also integrated care for foster children, which is I think significant. When I was in California, I had child welfare under me, and the lack of integration of health care and foster care was a big problem. So I think that was a huge step forward in our state.
Yeah, and I was just going to tag on to that, Joe, that how we do the foster care is we work with just one MCO for that. So there's one MCO for the entire state for foster care youth and transitioning youth out of foster care. So, and I think that continuity was probably a good idea. So that is that's unique to our system.
Great, thank you all. And then we've received a number of questions that are focused on clinical integration, including a few that are really asking about how this transition has affected, especially integration of care for more low acuity behavioral health services. So can you kind of speak to that question, whether that's what's happened to date or what efforts that are being planned to enable greater integration of care at the clinical level in the future?
A couple quick thoughts, and then I know Isabel and Joe would have other things to add, but we have a great committee here in the state. It's named after Dr. Robert Bree, and the Bree Collaborative produces standards on a regular basis around various topics. One of the things they had tackled right at the beginning of integrated managed care was behavioral health integration from the standpoint of the primary care setting. They established standards that we incorporated for the most part into our managed care contracts. And so that was one avenue to try to focus everyone's attention on a common approach. Also, around the same time that we started up integrated managed care, we were under, or still are under, a demonstration waiver agreement that pushed money out through accountable communities of health. The ACHs all tackled integrated clinical delivery of systems and transformation of healthcare delivery, and had different approaches in the different regions in terms of how they went about that work and supported providers to move in a more integrated fashion. Where we're at now in the last couple of years of that waiver is coming to agreement across the MCOs and the ACHs on a common way of assessing providers' capacity to deliver integrated care. And that aims to be settled by the end of this year so that we can collect statewide data around how providers are delivering many of those aspects of integration, like having a common care team, et cetera. Since so much of that effort has been on the medical side of the equation, we at Healthcare Authority are starting to work more on the behavioral health side, and as Isabel said, how to bring medical focus into the behavioral health setting as opposed to the reverse that the ACHs have been working more on.
Great, thank you so much, Alice. So then we received another question asking if the plans have been able to develop and retain sufficient behavioral health provider networks, and also how have rates for those providers generally changed during this evolution to integration?
I could speak for the North Sound region. I think at the urging of the State Healthcare Authority, the managed care organizations, when they took over, kept the rates the same. I think they were quite conscious about losing network capacity. I think, but by and large, they've been able to. I think COVID complicated everything. Some of our providers, we have had a few providers close facilities, partly related to the COVID and the cash flow. But I think by and large, at least in our region, they have been able to maintain their network. I think the issue that I raised in my presentation is that really we need to expand the network and invest in more capacity. And I think that's where more work has to be done.
Yeah, and I would just note that because of our delegated arrangement, King County was able to maintain largely the same payment methodology with providers as had been in place previous to the integrated managed care transition. That being said, we are modifying particularly our outpatient payment methodologies to tie our payment even more closely to encounters and actual service utilization, just because of course the actuaries set the overall Medicaid rates driven by encounter data.
And I would just add that, one of the areas that has been a challenge is to ensure providers are getting claims data to the state, that the claims are not getting rejected or denied. If a large portion of claims are getting rejected or denied, that means the encounter data is not getting to the state, and that will impact rates down the road. And so that is an area that is definitely a potential risk or concern. I know providers, that was a steep learning curve to do that. And then now with COVID, utilization's kind of wonky. And so anyway, that is just an area that has to be kind of scrutinized for rate setting in the future.
Great. And then we received a question on why was a fee-for-service payment model selected for services given the move to value-based payment, and that's happening nationally. So can you kind of speak to any sort of initiatives related to that transition to value-based payment?
Alice, do you want to take that, or?
Well, Isabel, you also mentioned it towards the end of yours, so I'll pass to you too. But I would say we have out on our public website at Healthcare Authority, we have tons of information about our goals around value-based payment. We also have an addendum to the managed care contract that's a bazillion pages long about our expectations around value-based payment. The MCOs have funds withheld from their contracts and then paid back based on whether they're achieving value-based payment goals. So it is a really high priority here, and over time we expect to keep on seeing it grow across all provider types. But Isabel, if you want to talk about
I'd like to add to this, and as background, I worked for the state for 5 years before I joined King County, and I designed and implemented a lot of integrated managed care statewide. And so I do want to clarify that providers can negotiate with the health plans on payment rates and methodology. So the state doesn't dictate to providers that they need to accept, for example, a fee-for-service payment methodology. But I think an issue that others should be aware of as they embark on something like integrated managed care is that behavioral health providers, especially smaller providers, don't have a history of negotiating with large private, commercial insurance plans, because at least in Washington, the behavioral health system is largely funded by Medicaid. So, sometimes you have managed care plans who provide a draft, proposed rate or contract to a provider, and it might be a fee-for-service payment methodology, and it might be tied directly to just the state's fee-for-service fee schedule. And providers who have never been in a negotiating position, may not understand what their negotiating abilities are, and they may take, what is proposed. And you do have managed care plans, even though the state, I think, is, as Alice said, has a value-based purchasing roadmap and requirements they're holding them to. But for some types of services, a preferred payment methodology is fee-for-service. So that's something to be very aware of, and that I think some regions did this in Washington, actually brought in consultants to do trainings for providers on how to negotiate and what they can negotiate and what they should look for in contracts. But I think that some of that is critical. And then, as Joe mentioned, there are certain types of services, the crisis system in particular, crisis stabilization, it's a firehouse 24/7 model. It doesn't work to be paid fee for service for those services. So those are just a lot of things to be mindful of in a transition like this.
And I might just add, from the provider standpoint, the information infrastructure that providers would need to collect and report outcome data, that structure simply isn't in place yet. And I think the MCOs were just trying to stabilize the network first, and then start trying to move it towards more of a value-based platform. But that's a significant undertaking.
Mm-hmm. And the MCOs, I'll just add lastly, need often some education as well on unique payment methodologies that exist in the behavioral health system that managed care plans, it's just not common in the physical health system. So there's some education on both sides.
Great. Thank you all so much. We have many more questions that we unfortunately just aren't able to answer all of them, as we're now at our time to wrap up. So while unfortunately we weren't able to answer every question that was asked, for those of you who are interested in learning more about advancing physical behavioral health integration, I'll share that we have a number of resources on this topic at our Center for Healthcare Strategies website, which is chcs.org. We will post this webinar, the recording. We will share the slides and welcome any follow-up questions if you have those. Also, please fill out the evaluation survey that will show up on your screen at the end of this webinar. We really value your feedback, and it will help us understand what topics you're looking for information about. And I just want to close today by thanking so much all of our presenters who shared really great, insightful remarks with us today, to the California Healthcare Foundation for making this webinar possible, and everyone who joined us on the webinar and shared your questions. Thank you all so much and have a great day.